Let's first talk about anatomy of peripheral nerves. So in upper limbs, from brachial plexus we have median nerve, ulnar nerve and dorsally radial nerve. In the lower limbs, from lumbosacral plexus anteriorly we have femoral nerve and posteriorly sciatic nerve. And sciatic nerve goes down at the popliteal fossa. It divides into tibial nerve and peroneal nerve. And if you see the one peripheral nerve, like let's suppose this is the median nerve. So inside one median nerve there are thousands of axons. So let's suppose there are a total 1000 axons. So among that 1000 axons there are some carrying sensory information, that are some are carrying motor fibers, some are sympathetic fibers. So let's suppose there are 200 axons that is carrying sympathetic fibers, 200 that is carrying proprioception, 200 that is carrying pain temperature, 400 carrying motor fibers. Let's assume this is median nerve. So motor fibers, they supply the flexor muscles of the forearm. So in this way a peripheral nerve is organized. So now let's talk about nerve conduction study after talking about anatomy. So this is the story of more than 100 years ago, when Hofmann was doing experiment with nerve conduction study. He was trying to estimate conduction velocity of peripheral nerves. So let's first of all draw a median nerve. So this is the arm, this is the elbow, and this is the thumb, this is the hand. And let's suppose this is the median nerve coming down here, and you know this is the on ventral aspect median nerve supplies abductor pollicis here. So this is the nerve terminal, and here you have abductor pollicis muscles, and this also supplies other muscles of flexor muscles and sensory supply to the fingers. And on this side we have ulnar nerve. So medial nerve supplies abductor pollicis muscles. Here when there is action potential comes, then acetylcholine is discharged and this muscle contracts, and thus we are able to abduct our thumb. So he thought that let's study this medial nerve. So he placed one electrode here, and at the wrist he placed another electrode. With this he gave current here, 3 milliampere current he gave here, and he had placed one electrode here. So he recorded the action potential that he got in this muscle. So it came 2 millivolt. So he thought that I can calculate this velocity by measuring the distance, because I know the distance upon time is velocity. So this is the distance from here to here is 4 centimeter. So let's write it 4 centimeter, and time it took for current to travel from here to here is 2 millisecond. So I get it 2 centimeter per millisecond, and this is the velocity of this median nerve. Then another thing clicked in his mind. Oh, there is neuromuscular junction. I am taking this whole distance from here to here, but this nerve is terminating here. So if I assume this is the total is 4 centimeter, so this may be 0.7 centimeter and this might be 3.3 centimeter, but I am taking this whole distance. So here it is becoming fallacy is occurring. So how can I overcome this? Is there any way I can overcome this? This NMJ junction is giving troubling. So he thought that let's do like this. Remove this electrode from here and place it here. So he placed here, and he again recorded the action potential. This time he got like 1.8 millivolt current, and the distance from here to abductor pollicis he measured 20 centimeter, and the time it took from here to reach here was 5 millisecond. So he thought that the distance from here to here is total is 20 centimeter, and distance from reached to here is 4 centimeter. So if I subtract 20 centimeter from 4 centimeter, I can get this distance. So let's subtract 20 centimeter, 4 centimeter from 20 centimeter. So it becomes 16 centimeter. And the time it took to travel from here to here is 5 millisecond. And time it took from travel to here is 2 millisecond. So the time it took to travel from here to here, if we subtract 2 from 5, we will get like this. So it becomes 16 centimeter divided by 3 millisecond. So 5.1 like centimeter per millisecond. So he thought that, oh, I was able to calculate this conduction velocity in this motor nerve. Interesting. So he analyzed this voltage. He thought that I am getting this 2 millivolt in this abductor pollicis. But again here another fallacy is occurring. What is the fallacy? I am recording the action potential in the muscle, but I am testing nerve. So let's call this compound muscle action potential, CMAP, because I am not just testing the action potential of the nerve, but also I am actually testing the action potential of the muscle, which gets its excitation from the acetylcholine that is released from the excitation of this nerve. So let's call this 2 millivolt compound motor action potential. And the distance it took to travel from here to here, that was 2 millisecond. So let's call this distal latency. And the distance it took from travel to here is 5 millisecond. That let's call this proximal latency. Latency means time. So he wrote in his paper that proximal latency, distal latency, and still we use the term latency, proximal latency, distal latency. We don't use proximal time, distal time, but it means the time. So he wrote it in his article, and since then we are following the same thing. Whatever one writes, we go on following like that. So this is the proximal latency and this is the distal latency. Now he thought this is about motor nerve. Now let's do this in sensory nerve. So since this median nerve is a mixed nerve, it has both motor fibers and sensory fibers. So let's place one electrode here and let's give current here and let's record the action potential here. So he give current here and placed electrode here in this index finger and he recorded, and he again got voltage 1.8 millivolt. So this is sensory nerve action potential. Since this time he is not measuring at muscle, so he did not use the term muscle, because this is the direct nerve that is measuring. It is measuring sensation. So sensory nerve action potential this time. Okay. And this is the conduction velocity. So what is the importance of knowing us these velocity, conduction velocity, distal latency, amplitude, or whatever we called action potential? This is actually amplitude, or we call it action potential, either sensory nerve action potential. So what is the importance of knowing these things? Because to differentiate from axonal neuropathy versus demyelinating neuropathy. In demyelination, what happens that, you know what is the function of myelin? Myelin makes the speed of conduction fast, because action potential jumps from here to here, here to here, here to here. It does not have to travel like this. So myelin makes the conduction fast. So if there is myelin are destroyed, let's suppose autoimmune attack occurred on the myelin and Schwann cells and myelin got destroyed. Now conduction becomes slow. So you know that demyelinating disease starts from distal nerves. So it starts distally. So when you test distal latency, it is decreased. If you give current here and record here, it will decrease. If you test proximal latency, it may be same. But if you test distal latency, initially distal latency is decreased, but later proximal latency may also be decreased. But initially characteristic feature of demyelinating is distal latency is decreased. And since myelin is lost, so conduction velocity will be decreased, because velocity will be decreased because it is slow conduction is occurring. But this conduction velocity and distal latency will be normal in axonal pathology. But amplitude is a function of axon. So if axons are intact, you will get the same amplitude. That's why in demyelinating disease you don't see decrease in amplitude. But if axons are completely damaged, let's suppose there is severe demyelination and that has ultimately led to axonal damage, then amplitude will be decreased in demyelinating disease also. But amplitude decrease means axon is damaged. Only myelin damage does not decrease amplitude. So this is the importance or implications of knowing about conduction velocity, distal latency, and so distal latency, conduction velocity, and amplitude or action potential. Now let's talk about the concept of temporal dispersion and conduction block. So to Dr. Hoffman, one patient of Saturday night palsy came. So what is Saturday night palsy? You know that in a spiral groove of humerus there is radial nerve. It is traveling like this and goes down the dorsal aspect of the arm and supplies the extensor muscles. So if there is Saturday night palsy, patient won't be able to do wrist extension because there is wrist drop. So let's see, this is the arm, this is the elbow, and this is the hand, and this is the spiral groove. Through this radial nerve travels and it comes back like this and supplies the extensor pollicis, extensor indicis. Okay. And here radial nerve is compressed here. So what he did, that he placed electrode here on the radial nerve. Mind that this is the dorsal aspect. Okay, so this is the radial nerve, and initially I had illustrated in ventral aspect, median nerve. This is the dorsal aspect, this side. So this is the radial nerve. So he placed electrode here and another electrode here in the extensor indicis. So in the extensor indicis he measured the action potential on these muscles and he gave current at wrist and he recorded it and he found like that. Let's 20 millivolt and the duration of this was 1 mm. Okay. So he again he removed from this current generator or the electrode, he removed from this and he placed it here, and what he found, that it became like this. It became 90 millivolt and it became 2 mm. He again placed it here and what he found, that it became 18 millivolt and it became 3 mm. And he placed it here now, and what he found, that it became 4 millivolt. It became 4 millivolt and like this. So it became like 7 mm and 4 millivolt. There are sudden change when he went to distally proximally above the spiral groove. So he thought that his nerve is intact till this point, but still this is decreasing. What is this going on? And still this area is increasing. This is 1 mm, this is 2 mm in the graph, is 3 mm, here it has 7 mm. So I can understand this because there is some pathology here, but what is going on this? So he called some healthy volunteers because he thought that he is diseased person, so he may be having some other problems in his nerve along as well. So let's study in some more healthy volunteers. And what he found that in all persons it was following like this was following like this, but at this point in them what was occurring like? It was occurring like this. So it was 16 millivolt and it was 4 mm. So still it was decreasing, 20 millivolt, 19, 18, and in healthy volunteer this was also in downward trend. But there is sudden drop, but here in healthy volunteers also this was in downward trend, and this base was increasing 1 mm, 2 mm, 3 mm, 4 mm. So he published an article. So I am finding some interesting fact. As I go proximally and placing the electrode, the base is increasing, amplitude is decreasing. What is going on here? So physiologists again started researching on this. What is the thing? What is occurring like this? And what they found that, I am now explaining this in simple language. So let's assume this is the road, and this road, from here is the start and here is the end. Here 50 car race started. The race of 50 cars started, and let's suppose 25 car had a maximum limit of 140 km per hour, and 25 car had maximum speed of 200 km per hour. So maximum speed, and all the drivers were ready to start their cars at max speed. So they started all at max speed. The race started. What happens that initially when the race started, all the cars are concentrated at one place or one point, because all looks concentrated. But as it reaches to the destination, you will find that some cars get concentrated at the destination, some is still back, whose speed are less, still back. So initially they are concentrated, but as they reach to the destination, they start separating, because their speed of these two cars are different, of these 25 cars are different. That's why they are separating. But initially they are at almost same distance, or only little separated, but here it is vast separation. Why I illustrated this? Because the same concept is here. Because you know, in the radial nerve we have both slow fibers and fast fibers. Radial nerve does not comprise of only one type of fiber, it has multiple type of fibers. So both slow fibers and fast fibers. So let's assume this is the radial nerve and there are 100 fast fibers and 100 slow fibers. So this is from here to here. Let's suppose there are multiple slow fibers and multiple fast fibers. So when we give current here and when we record here, so it becomes the phenomenon like the cars at the initial point. So the fast fibers gives amplitude like this, let's suppose. The slow fibers also look concentrated here, little slow, but they start merging like this. Okay, so there is not much difference or separation between that. Let me draw it again. Let's say, and slow fibers are coming like this, let's suppose. But the machine, the computer won't give you like this slow fiber separately and fast fiber separately. They will merge these two and give you compound action potential. And but when you place this at here, when you go proximally, what happens that this separation starts to emanate. Like fast fibers are like this, and slow fibers starts coming like this. So this, as you go proximally and record here, so the distance increases. When you are giving current here and recording here, the distance was less, but you are now going here and recording at here, so the distance increases, so this area increases. That's why this 1 mm, 2 mm, 3 mm is increasing. And again you go at this point, what happens that again this fast fiber came and slow fiber is still coming like this. So here you see this area has increased to this, like here 1 mm, here 2 mm, here 3 mm. So this area is increasing. We call this area. This is actually length, but in our nerve study we call it area, and this call it amplitude. And what are you seeing? This amplitude is decreasing. Why this amplitude is decreasing? Because let's suppose you give 3 milliampere current here and recorded here, so there was less decay in current, but you are giving 3 milliampere current here and recording here, there will be more decay in current, so voltage will decrease. But when you go more proximally and giving the same amount of current, then what happens? More decay will occur. So as you go proximally and giving same amount of current, but the distance is increasing, so voltage at the terminal site will decrease, so amplitude will decrease. So this is the normal phenomenon. Healthy person also have. If you test my radial nerve will also like this, but in this person there was vast drop. So they later found that, and the neurologist agreed that if it is greater than 30% decrease in the amplitude, or the area increases more than 30%, then we can call this pathological. The nerve has problem. Here patient has Saturday night palsy. That's why he has more decrease in amplitude and the area has increased. So Dr. Hoffman thought that I did experiment in upper limb. Now let's do experiment in lower limbs, because there are also nerves in lower limbs. So you know that posteriorly we have sciatic nerve that divides into tibial nerve. So let's assume this is the foot, leg, and this is the foot, and here tibial nerve comes. At the popliteal fossa, sciatic nerve divides and it gives tibial nerve. It supplies the gastrocnemius muscles, and the nerve fiber goes like this, and it supplies the flexor muscles of the foot, like flexor hallucis, and flexors of these other toes as well. So he placed one electrode at flexor hallucis and he gave current here, and he recorded the amplitude voltage at flexor hallucis, and he found like this. So he thought that I gave current and this amplitude came, this voltage came, I can understand, but what is this small wave? Why this wave came? I am not able to understand. Initially I tested in upper limbs, I tested in so much healthy volunteers as well. I did not got this wave. What is going on here? So let me again test on those all healthy volunteers, because if we can test in many persons, then we can confirm that, oh, this is not abnormal, or we can conclude something from that. So he called many healthy volunteers and he tested again on all those, and here again getting like this. What is this? Oh my goodness, this is some artifact or what? So since I got in foot, so let's call F wave, because initially I did in hand, I did not get it, but I did in foot and I am getting it. But I am getting this in almost all healthy volunteers. So let's call it F wave, and he published it article. So there is new interesting thing, F wave. So physiologists started studying this, why it is occurring like this. So what they found that when you give current here, what happens that this current travels down this path, but current does not understand that I have to go down. it can go up as well, because this is the tibial nerve and this is the continuation of sciatic nerve. So the sciatic nerve, you know, it is coming from lumbosacral plexus, and lumbosacral plexus, from where it is coming? It is coming from anterior horn. This is the anterior horn and this is the posterior horn, and you know, ultimately from it forms a spinal nerves, and this is the nucleus or cell body, and this current, what happens that this current, in addition to going downward, it goes like this, and again it is reflected back, and again it goes to the foot. So initially this current goes and he gets this big amplitude, but this current also goes like this back and again reverts back it, and there will be some decay in the current. So afterwards it gets a small wave, because there is decay in current. So that current had to travel this much distance and again has to travel back here. So the current got a smaller voltage. That's why there is a small voltage. And later neurophysiologists also found that we are getting in hand. They thought that what is special in foot? If it is this phenomenon, then we can get in upper limb as well. Then I started doing experiments in upper limbs of healthy volunteers, and they found that we are getting in upper limbs as well. There is nothing in lower limb. But Dr. Hoffman called it EF wave. So let's write him EF wave. We will also call it EF wave. There is no harm in telling that it is EF wave, but it is also in harm. We can also call it A wave or whatever you like. But by convention, let's call it EF wave. But Hoffman was still not satisfied. He thought that his teacher had taught him ankle reflex, and he had studied what is the reflex pathway of ankle reflex. So he thought that when we elicit ankle reflex, when you hit the Achilles tendon, what happens that 1A sensory fibers goes to the spinal cord. This fiber goes to the spinal cord. This time this is the sensory fibers and this goes to dorsal horn. And from here, since it is monosynaptic reflex, it excites this S1 nerve and it gastrocnemius contracts, and thus plantar flexion occurs. So this is called ankle reflex. Ankle reflex. So let's do one experiment. Rather than hitting with tendon, let's give current here. This 1A afferent fiber. So he gave current, and what happened that this current came here and this excited gastrocnemius muscles. So he thought that, oh, this time I have good opportunity. Let's call it Hoffman reflex. Hoffman reflex, or abbreviated as Yates reflex. Yates reflex. Since then, in the literature, the concept of Yates reflex came. So everyone started telling it is Yates reflex, Yates reflex. But Yates reflex also can be got in upper arm, lower limb, upper limb, whatever, because the pathway is like this. So why do you need to know about EF wave and Yates reflex? For clinicians, you know that in Guillain-Barré syndrome, EF wave and Yates reflex is decreased. Normally it is present because it is normal phenomenon, but in Guillain-Barré syndrome, it is decreased. That's why we need to know. You know what is Guillain-Barré syndrome? It is demyelinating polyneuropathy. It may be axonal as well, but one variant is acute demyelinating polyneuropathy. Have you ever thought one thing? Why do you get protein in CSF in demyelinating peripheral neuropathy? The problem is in the peripheral nerves, but we are getting protein in CSF. Why it is like that? So I had thought once and I searched it, and what I found that if you see a spinal cord, this is the dorsal horn and this is the anterior horn, and you know that this is the pia mater that is enseething this substance of a spinal cord, and around this arachnoid matter, and here it is the CSF, and you know that these nerve roots exits through this CSF, and you know these are myelinated fibers. These motor fibers are myelinated. And in Guillain-Barré syndrome, what happens that blood nerve barrier is broken at this point, at the exit point. Where is it exiting? It is in the CSF. This initial part is in CSF. So when the blood nerve barrier is broken, what is blood nerve barrier? You may have heard about blood brain barrier. So similar concept is that nerve also does not allow everything to come to its environment. Nerve is also protected or sacred area like brain. So it does not allow everyone to come to his palace, to his place. So there is some barrier that is called blood nerve barrier. So T cells, B cells are not allowed here, because you will destroy my myelin. I know that. So you are all out, because I have some barrier and barrier is closed. But when that barrier is broken, the T cells, B cells starts migrating there and starts destroying the myelin, and that is called demyelinating polyneuropathy. So when it starts demyelinating here, what happens that this myelin protein starts leaking in the CSF, and that's why you see CSF protein increased in Guillain-Barré syndrome. Why I told this? Because this has implication here in the F wave and H reflex. F wave, what I told initially, that what is F wave? F wave, when you give current here, like let's suppose this is the nerve, so the current goes downward as well and upward as well. So whatever the current goes upward, it is reflected from this cell body, and again you record in the muscle, that is F wave. But here what is occurring in Guillain-Barré syndrome? This proximal part is the demyelinated. It is not able to conduct properly at that velocity, that fast velocity. So what happens that this current goes here fast, but here it is encountering block. It is going slowly. That's why it goes slowly here and it returns back slowly. So you see that like this, and F wave becomes delayed. So we call F wave latency. Or if it encounters much resistance, so it dies in the while it coming to it, because you know that F wave is a small amplitude. Whatever the current it has gone, it has to come back, and in the process of returning back, some current dies because the amplitude goes down, and here it encounters such high resistance that coming here the amplitude dies and you can't get F wave, or F wave is delayed. So that is the problem. So if you see absent wave or delayed F wave, you can think Guillain-Barré syndrome. The problem is in the root. That's why F wave have difficulty returning. Or H reflex. H reflex also normal phenomenon. But what happens that these sensory fibers goes to the sensory, and this is monosynaptic and it comes back. When it comes back, what happens that there is delayed conduction. So it is encountering resistance here. So H reflex might be absent in Guillain-Barré syndrome.